Versio, the chair for pediatrics here this morning for our fourth week of RUHS webinars. First, we're going to cover the statistics for the county. We have so far performed just over 30,000 tests. There are 28 confirmed cases, 236 are hospitalized currently, with 76 of those in the ICU. And then, unfortunately, the deaths have continued to rise with 85 so far as of this morning. If you look at the hot spots on the graphic of the county, they are in Riverside, Marina Valley, and then there's also one in Indio, it looks like. I thought also we could cover a little bit about San Bernardino, our neighboring county, this morning. They have tested so far about 13,000 patients with about 1,400 positive cases, 10.5% positive rate for their tests, and then about 60 deaths so far. If you're interested in other resources for kind of following this this COVID situation, the LA Times has a great website that shows a lot of different things. One of the interesting things is it has the curve tracker, and so you can see, or the doubling rate tracker, and so you can see how quickly different counties are having their doubling rate. And then, you know, as probably many of you are aware, there's a lot of different factors that go into this. You know, part of it is testing availability, and I don't know, you know, what the testing availability is across all of the counties. But fortunately, it looks like a lot of the rural counties so far are not having a significant number of cases. So that's kind of the status of this, you know, the numbers. We have today with us Krista Chi, who's a clinical pharmacist in the ED and has worked very closely with our medication shortage group. And so she has a PowerPoint that she's prepared and is going to go through with us that's going to address alternative mechanisms for analgesia and sedation. And so I'll just go ahead and let Krista get started with that.
Thank you, Dr. Versio. Let me share my screen. Okay, can you guys see my screen okay?
Yes,
okay,
looks great. Thank you.
All right, so last week, our Assistant Director of Pharmacy had presented an overview of all of the strategies that the Department of Pharmacy had implemented in collaboration with our providers, nurses, respiratory therapists, and other ancillary staff. So today I'm focusing on one specific aspect of our conservation strategies, which is Analgosedation. So why conserve? Because the balance of demand and supply had been interrupted as hospitals nationwide are preparing for and dealing with a surge in cases of COVID-19. So the cause of shortage is often twofold. So let's take a look at both supply and demand. Okay, so shortages in general are not really new to us. There are various causes for a reduction in the supply chain, including what I have listed here. So first, there could be quality issues and recalls that would occur, and this may not be apparent to those in the front line, but our pharmacy staff are notified to check on all of our inventory when recalls happen to remove them from existing stock. So I believe that I've seen more of this in recent years. And sometimes due to diminished profit margins, less manufacturers choose to make specific products, making that product much more vulnerable to any bump in demand. And lastly, there could be production issues. So medication manufacturing can be quite complex in nature. A lot of us are well aware of the major manufacturers and companies in the market that produce these medications. I'm not going to list their names since the majority of us in healthcare are well aware of them. However, we may not really think about what goes on behind the scenes. The fact that the company name on the bottle or packaging are not necessarily the company that actually make the medication. So often, these large companies will contract with other manufacturers to produce either parts of the medication, such as raw ingredients, or the assembly of these products, or both. So the majority of pharmaceutical ingredients are actually made outside of the United States, most notably China and India. So these overseas companies will calculate and project demand for the next few years based on historical needs. Often a pandemic or a sudden prolonged disruption in production is not part of their calculation, and currently we're experiencing both. So in late February, the FDA had issued statement regarding the shortage of active ingredients manufactured and imported from areas of the world that was heavily impacted by COVID-19 pandemic, such as China, and acetaminophen would be an example of this. So FDA had been in touch since then with over 180 manufacturers and identified 20 plus drug products in this affected category at that time. So from the supply end, we know that we're facing some shortages, and that's actually, constantly evolving as the pandemic kind of plays out. So in terms of demand, right, after the medications are manufactured, they go to wholesale distributors such as AmerisourceBergen, Cardinal, or McKesson. These companies actually have their own way of inventory keeping and demand calculations. So our pharmacy, as well as many others across the nation, will procure medications from one of these wholesalers. If we see an increase in demand evidenced by increased utility or dispensing activities, our frontline pharmacists will notify our pharmacy leadership for procurement team to increase ordering. Okay, we also have a pretty complex mechanism of reviewing, keeping track of utilization, which I'm not really going to go into detail about. Institutional need. However, during a nationwide shortage, the wholesalers also have a process for controlling distribution by allocation. So when a drug goes on allocation, we're limited to obtain a very specific amount that is actually determined by historical usage. So this process is good in that it prevents any one particular pharmacy, okay, from hoarding shortage items. That allows a much more even distribution across all of the institutions.
Hey, Christine, sorry to interrupt. It looks like we lost your PowerPoint, so I pulled it up and shared mine. So I had you on the demands slide. Let me just know when you kind of want to go to the next one.
Okay, can you still hear me okay?
Yep.
Okay, perfect. Okay, so where are we? Okay, so the process of allocation, right? So it's good that it, can distribute more evenly across institutions. However, unfortunately, it does not really prepare us from meeting our needs if there is truly a surge in demand. So an example of surge in demand during the COVID-19 pandemic would be propofol. So manufacturers have not really reported any issues with production, but there is a shortage because the demand has skyrocketed. So anecdotally, COVID-19 patients on vent really requires higher doses of sedation. And this has also added to the consumption of sedatives, such as propofol, just in general. All right, so we can go to the next one.
Okay.
So the presentation today, right, we're just trying to address one of these areas where conservation is key in maintaining optimal care of our patients during a shortage period, where while still accommodating a surge of patient demand. Okay, so during the pandemic, we have an increased number of patients on requiring ventilation, which also means an increased utilization in analgesic sedatives and potentially paralytic. So I listed here some of the medications that we have the most severe shortage for. Not surprisingly, these are some of the frontline agents that we're used to having, right, for a patient on mechanical ventilation. And some of these shortages are really not new to us. For example, fentanyl has been on and off our shortage since 2018. So we've been able to meet our patient demands for the most part, and I really have to applaud our leadership and procurement team on that. However, shortage is now compounded by a surge of demand, and this is a very, very troublesome combination for us. So the COVID-19 Clinical Pharmacy Task Force, in collaboration with the Critical Care COVID-19 Clinical Group, had developed an algorithm to help guide us during this challenging time to conserve our medications on shortage. So next, we're going to look at some of our conservation strategies. Okay, so the next slide, we'll start with RSI. There has been no major changes in recommendation in this process because our first line agent for induction and paralysis still remains etomidate and cytokine. Both of these agents are in sufficient supply at this time. We simply just want to remind everybody to conserve some of the later line agents for continuous infusions. Okay. However, we also understand that there are instances where utilizing a second line agent cannot be avoided. So for example, with patients with a history of malignant hyperthermia or with conditions predisposing them to, or with known hyperkalemia, we really want to use rocuronium to be safe. So, I mean, in terms of rocuronium, sometimes I also get the question of, so how much does a dose of soxocholine actually increase potassium? It is on average about 0.55 transiently, and some reports say up to 1, and there are some very dramatic reports of significantly higher numbers, but those would be, very atypical. For post-intubation, we're starting now to see some changes to what we're used to seeing as first-line agents. So now these recommendations, again, are derived from both our institutional availability of these medications and as well as clinical experience from colleagues in some of the more hard-hit areas of the pandemic. So during phase 4 of SURGE, we recommend starting patients on midazolam drip post-intubation over propofol. Okay, and then we also have an alternative of either dexmedetomidine or ketamine infusion. And some of us have already started this practice actually, so that we can reserve propofol for patients with traumatic brain injury or elevation intracranial pressure, or patients requiring deep sedation where sedation goal is not really met by alternative agents, essentially the more refractory cases. Moving on to phase 5, then we're actually going to start with IV pushes, really just to kind of, again, give us a little bit more extra time to try to figure out their regimen before we just start them on continuous infusions. Okay, so next slide. So for the next slide, we have the ICU Analgesia algorithm. So we've really had to break it down to 2 different categories of patients, either paralyzed or non-paralyzed patients. For non-paralyzed patients, we want to start with an oral route. So that means we're looking into acetaminophen, oxycodone, and hydromorphone in oral routes of administration or NGP. So after, if that does not work, then we can consider either IV pushes or continuous infusion, and with hydromorphone being the first line agent at this time. So we could potentially also add adjunctively ketamine infusion. And lastly, fentanyl, because we do have very, very limited supply of fentanyl on hand. And for patients who are paralyzed, obviously, PO would not be the best option. So we can start these patients on IV infusion or IV pushes, and then we'll go from there to assess the need of these patients. And then for patients who demonstrated opioid tolerance, right, then we could consider putting them on something a little bit more long-term, like a fentanyl patch. And then there are some alternative strategies in multimodal pain management that we can also employ to help make sure that the pain management is optimal for these patients. Okay, so the next slide, we have our sedation algorithm. Okay. So generally speaking, for patients who are not paralyzed, we are aiming for a light sedation goal of RASS -1. So again, we're looking at PO or NG access initially. I understand that this is not very typical, but this is something that's necessary, especially if the volume actually significantly increases for this particular population. Okay. So for patients, again, who are not paralyzed, we start with PO-NG, and assuming, of course, they have a functional GI, and then we can move down to some IV pushes and then infusion options. So our first line option here would be, again, midazolam and or Precedex. And then second line for ketamine, and then third line phenobarbital. So that's also an interesting medication. We have not really used phenobarbital for ICU sedation for quite some time. So now we're kind of bringing out some of the ODs. I will also discuss specifically, the properties of some of these medications to ensure that we can use them, safely and optimally for our patients. And then, of course, the last line agent we have here is propofol. Again, we do have a very severe shortage. Now, there are some exceptions for utilizing propofol. Again, patients with traumatic brain injury, elevations in ICP, or, for these patients, we can actually start them right away on propofol. Okay, so for patients who are paralyzed, then we're going to shoot for a deep sedation goal of -4 to -5. For these patients, we would consider propofol as first-line agent because a lot of times some of the alternatives are not able to get us to where we want them to be. And if they're able to have a RAS score of -4, -5 on alternative agents, then we're happy to just kind of stay with those agents onward. And then, of course, we have second line midazolam and third line phenobarbital here as well. Okay. And so the last part of the algorithm is just a little bit on paralysis. So if the patient requires paralysis, we want to start with intermittent IV pushes, actually, to facilitate and protect lung ventilation. So we want to advance to continuous IV infusion if patient has persistent vent dysynchrony with need for ongoing deep sedation and prone ventilation and persistent high plateau pressures. So these criteria are actually defined by SCCM recommendations for COVID-19 patients on ventilation. We will use for our institutional rocuronium as our first line agent, as it is much more available, and reserve cisatracurium for patients with multi-organ failure. So again, some of these patients would really be better off on cisatracurium, and then we'll also look at these drugs in a little bit more detail later. Okay, so all the algorithms I've just presented would be a summary of our preferred lines of treatment during this COVID-19 pandemic. We actually spoke about some of the alternative routes administration for analgosedation, such as PONG routes. And we're not really used to seeing this in a routine kind of basis. However, we still need to recognize, right, there are some caveats. So in terms of pros, the biggest advantage during this time is really oral meds are much more available. However, there are also things that we cannot really ignore, right? For patients who are critically ill on vent, they're not always going to tolerate PO or NG route. And we also have to consider their aspiration risk and try to prevent that, right, with preemptive measures. And there are also some PK changes, right? So PK, or pharmacokinetics, describes the relationship between the dose administered and the changes in drug concentration in the body over time. So for patients who are critically ill, right, it's fairly well observed that they have reduced and delayed absorption due to either impaired gastric motility, which is actually more often than we would think, and also as a result reduces the peak drug concentration. So what does that mean? That means for patients who are critically ill, normal doses may or may not be enough for them, right? And then how do you gauge that when they're on ventilation? And then also there may be some altered metabolism, right? There are examples would be a number of opioid analgesics like codeine, hydrocodone, oxycodone, tramadol. All of these things rely on actually in vivo conversion into more opioids for their analgesic properties. So on our algorithm, we have oxycodone, for example. So oxycodone metabolism actually entails the conversion of oxycodone into oxymorphone by one of the cytochrome P450 proteins, CYP2D6. So the metabolite oxymorphone is 14 times as potent as oxycodone. And this is really part of how oxycodone exerts its analgesic activity. However, for patients with critical illness, a lot of times their hepatic function is not quite the same. So as a result, you may actually see significantly reduced analgesic function. And of course, there are also just really inherent polymorphisms of these enzymes. So it's a little bit harder, right, to gauge for the frontline staff in terms of their pain control. Okay, and then we are also seeing a little bit more of the IV pushes, intermittent IV pushes. So that's the next slide. The pros of IV push is that it has much quicker onset of action, right? But it also tends to be a little bit more labor intensive. So again, our frontline staff will have to kind of go in and assess these patients, usually on a schedule basis or PRN basis. And with the longer acting agents, a lot of times that we use for IV pushes, they can actually stack up over time, and it's a little bit less predictable than someone that's on continuous infusion, because those products or those medications tend to be much shorter acting. Okay, so next, I actually have here a ecoanalgesic chart to kind of help everybody gauge, the various different opioids and how to convert them between each product. So in terms of analgesic dose for IV agents, I like to remember them as just kind of typical doses, right? So 5 milligrams of morphine would be equivalent to 0.75 hydromorphone, which is equivalent to 50 mics of fentanyl. And these are very typical doses, and that's how they look like. So everything is typically compared to morphine when it comes to these equal analgesic kind of dosing charts. And we also have something here for everyone if we have somebody who has demonstrated opioid tolerance. And so the definition of opioid tolerance is previous opioid usage for at least 7 days with minimum opioid dosage of 60 milligrams of PO morphine. So for these patients, we can consider converting them to longer acting agents, such as fentanyl patches. But I just have to remind everybody, fentanyl patches, the onset will be about 6 hours. And really, you don't reach steady state until about 24 hours after the patch is placed. So for the first day, when they start on the patch, we still have to be very cognizant in assessing their pain level, because we will probably need some PRN pain meds for them to be able to control their pain. All right, so next we're gonna look at some of the comparisons of how these agents are in comparison to each other. So that way, really as a quick review, especially for agents that maybe we haven't been using as much lately. So first, we have analgesics, right? So for analgesics, I have here just 2 major categories of opioids. So you have your phenanthrines and also phenylpiperidine opioids. So in terms of phenanthrines, we have morphine and hydromorphone. I can tell you right now that we definitely have more morphine and hydromorphone available in the pharmacy than we do fentanyl and some of these other alternatives. So hydromorphone is becoming more and more of a first-line agent in our pain management for the critically ill population. So I just want to remind everybody, though, for both morphine and hydromorphone, we want to be kind of careful in terms of their renal and hepatic function. So with morphine, there's really no defined dose adjustment for renal or hepatic failure. However, for hydromorphone, you actually have specific dose reduction, and I've listed it here. There's like a 50% dose reduction for creatinine clearance of less than 60. So as a general rule of thumb, for IV pushes, you want to just half the dose for those patients, and then further half the dose if their creatinine clearance is even lower, of less than 30. So if they're on continuous infusion, we want to start them on very, very low doses and then go from there. And then when it comes to really the phenylpiperidine agents, so fentanyl is pretty much considered the frontline agent, right? However, it's in very, very severe shortage. So for the most part, we have very, very limited supply. There are some other alternatives that are more similar to fentanyl that I listed here. So we have remifentanil or sufentanil. So in comparison to fentanyl, remifentanil is actually a very, very extremely short-acting agent, and it's the least likely to accumulate. It's actually a pretty ideal for continuous infusion. However, there is also a very limited supply of this particular medication. And for patients who you're really, really concerned about accumulation, they have a lot of, organ dysfunction, this could be a possible agent. So again, for the multi-organ failure type of patient population. And then next we have sufentanil. So sufentanil is actually extremely similar to fentanyl. They both have active metabolites. They all both kind of undergo some level of hepatic metabolism, and they both have, a little bit of kind of accumulation perhaps with renal dysfunction. However, sufentanil is really not used as frequently in the front line. So I do want to caution everybody in that even though it behaves very similarly to fentanyl, it is significantly more potent as reflected by sort of the dosing of sufentanil. So it's about 7.5 to 10 times more potent than fentanyl. So we just want to make sure it is not a one-to-one type of conversion, so we can't use it quite like we do fentanyl. But we do have some supply of sufentanil available in the pharmacy, and that can be utilized for continuous infusion. Right. So next, we're going to take a look at sedatives. So we have a lot more alternatives in the sedatives category. So a big category would be benzodiazepines. And so right now, we want everybody to really start thinking about starting sedation with midazolam as a first-line agent. Really, the biggest reason is we have more of this available. Okay, so we do, again, want to monitor for hypotension, reflex tachycardia. It's typically not that significant unless the patient is hypovolemic or you're really co-administering with additional centrally acting analgesics, which they probably will be getting. So we should be monitoring these patients with their hemodynamics. And then, of course, the next benzo in the category that we may see would be lorazepam. Now, lorazepam is actually pretty rarely used as a continuous infusion, really because, one, it is a longer acting agent, so you'll see it, or it should probably be used as an IV push drug. And another big reason is because it contains polyethylene glycol or propylene glycol solvents, which could cause some issues such as acute tubular necrosis or lactic acidosis with prolonged administration. So it really is not the safest agent to use as a continuous infusion. Now, if we're going to do it for a short period of time, then that's absolutely okay. However, if we're looking at somebody who's ventilated on sort of a couple of days at least of mechanical ventilation, this is really not the best agent to use for continuous infusion. Okay, so next benzo we have is diazepam. Diazepam is just not used as continuous infusion in general because it has an extremely long half-life. In fact, it has active metabolites with half-lives of 36 to 90 hours. So for some patients, it's actually gone up to like 12 days when they have some level of hepatic impairment. So this is one of those agents that could really stick around for a very, very long time as patients get progressively ill. So again, so we can use diazepam as an IV push agent, especially if they're not super sick. You can give them sort of like that initial doses to get their sedation started, but really as a long-term agent, really not ideal. Okay, so next we have dexmedetomidine with Precedex, which is a very unique sedation agent. It's an alpha-2 adrenergic agonist. It's centrally acting. So it's a very, very short-acting agent. It's essentially a IV, more sedating form of clonidine. So not surprisingly, some of the side effects would include hypotension. In fact, about 24 to 56% of patients will experience some level of hypotension when they're on Precedex. And of course, there's also potential for bradycardia and sinus arrest if it is given as rapid IV. Okay, so again, there is an initial bolus dose, which is optional. So that really depends on the hemodynamic stability of your patient and how they're able to really tolerate Precedex with a loading dose. Now, a lot of times our providers will just decide not to load them, to be safe. But we have to keep in mind, if we don't load these patients on Precedex, it takes a good 30 to 60 minutes to really kick in. So, sometimes I would say from just my experience, it takes probably about 45 minutes on average for you to start to see the sedating effects of Precedex once they start the drip without a loading dose. So with that in mind, we know that once we intubate somebody, that one dose of etomidate is not going to last 45 minutes, that's for sure. So we really do need to give them something else, IV push, if you decide to start them on Precedex. So that, and not bolus them, so that they will have sufficient time for sedation to actually kick in. So again, recently there's more and more kind of momentum to move toward Precedex, really just because it is very short acting and because of its unique mechanism of action. It tends to not accumulate or cause any issues such as ICU delirium. So that's, that's a really kind of enticing thing, right? So Precedex, again, has become more and more really popular in more recent years. And so next we have an oldie but goodie. So we have our non-competitive NMDA receptor antagonist, ketamine. So ketamine is a very unique agent in that the side effects are just really the opposite of all your other sedatives, right? So, instead of, potential for decreased blood pressure, decreased cardiac output, it actually increases heart rate, blood pressure, cardiac output. It also has a side effect that could potentially be desirable. It causes some level of bronchodilation. So for patients with, refractory asthma, for example, this could actually help them, open up their airway. However, it also increases myocardial oxygen demand. So we want to avoid using it for patients with MI, recent MI, or sort of ischemic heart conditions where, you know, you could actually potentially push them into more ischemic condition, you know, situation. And for adults, for certain patients, they may have an emergence reaction, meaning that, you know, once you start to kind of wake them up and try to pull them off of ketamine, they're going to have dreamlike state, and some of them will act just really agitated because, you know, they're not really seeing the reality very much. So for these patients, we can give a little bit of the benzo, like, you know, 2 milligrams per set, for example, to kind of just tide them over so that they can wean off of it more smoothly. And also salivary and respiratory secretions can occur most of the time in pediatric patients. For adults, it's not as often, but I have personally seen it happen. So when that happens, it's a good idea to give them something that's anticholinergic to dry them up a little bit, like scopolamine or even a little bit of atropine. Okay, so moving on our algorithm, we also spoke about phenobarbital as IV pushes, right? So so anything that I kind of grayed out are drugs that we're not really using for continuous infusion. So these are really just IV push only agents. We can start them on 30 to 65 milligrams IV push every 6 hours with a maximum of about 400 milligrams per day. So again, you know, so these drugs are very hepatically, extensively hepatically cleared. So there are actually a lot of isozyme metabolism. As a result, there's a lot of drug interactions with phenobarbital. So we just have to be cognizant, you know, once these medication lists becomes longer and longer, we really need to assess these patients to make sure that they're not going to have any interactions and issues. So lastly, we have our non-barbiturate sedatives such as propofol and etomidate. So propofol is currently experiencing a very, very severe shortage. So we're really trying to limit it to patients who absolutely need to have it. So again, so these are patients with traumatic brain injury, right, with elevations in ICP, because propofol was shown to actually decrease CPP and ICP and cerebral oxygen demand. I do want to kind of just mention allergies. So propofol is kind of formulated in certain oils, such as soybean or egg. So we just want to watch out for that. And there are certain like European formulations that even may have some peanut oil components. So we just want to make sure that our patients will not have any issues with it, you know, when they're getting propofol. But right now, we're really trying to reserve propofol for, again, patients who really, really require it, or for patients whose sedation goal can just not be met with all of the alternatives that we've just mentioned. And then lastly, for etomidate, we really don't use etomidate for continuous infusion. It's usually an IV push dose, most frequently seen in RSI. And it is the drug of choice for RSI, and we will continue to use it as the drug of choice for RSI. We do have sufficient supply. So that pretty much rounds up all of the sedatives that we have in our arsenal currently. So again, just kind of need to be mindful that they will behave differently in these patients. And some of the older drugs that's fallen out of favor did fall out of favor for a reason. A lot of times it's really accumulation, or some studies shown that it's associated with increased risk of ICU delirium, so like the benzos. So we just need to be very cognizant of that and make sure that we're able to provide them enough sedation at the same time, recognize, you know, how they're doing so that we don't actually have significant accumulation in the patient's system. All right, so the last group I want to have a quick comparison for are your neuromuscular blockade agents. So we have really a couple in stock right now. We have vecuronium, rocuronium, also cisatracurium. So in terms of availability, the most available agent right now would be rocuronium. And so this particular agent has some moderate metabolism with you know, in the liver. So we do need to be a little bit more careful when they're on continuous infusion if they have significant hepatic impairment. So cisatracurium, we have a very limited supply of. This is one of those agents that goes through Hoffman elimination, which means it really is not impacted by renal or hepatic function. It clears, right? So extrahepatically, it's not really depending on any of these organ functions. So as a result, it is really preferred for patients with multi-organ failure. And so we want to really reserve this agent for those patients. And then, of course, succinylcholine, again, is not utilized for continuous infusion. However, we do use it for RSI. Okay, so this is pretty much a summary of comparisons. Now, I kind of want to mention just a few things for special considerations. Okay, so the next slide. So I want to talk a little bit about what happens really with these patients that you may not immediately associate with sort of drug clearance, drug concentration. So one thing would be PEEP. So for, we know that, when patients go into ARDS, which, some of these COVID patients seem to do, we will start to increase their PEEP, right, on the ventilator. So you don't really think about ventilators and drug really in the same sentence most of the time. However, it significantly actually impacts the clearance of some of these drug products, really depending on their characteristics. So an increase in PEEP may lower your cardiac output and increase the back pressure to your liver venous outflow and hence your venous resistance. So that could cause a reduction in your hepatic blood flow. So when that happens, right, for drugs that really depends on hepatic blood flow, their clearance will also diminish as a result have significant accumulation. So which drugs are most impacted by this? So these are drugs with something we call with high hepatic extraction ratio. So high extraction ratio, what does that mean? So these are drugs that just dissociate from blood and enters hepatocytes and undergoes biotransformation very quickly. So then they actually are not impacted by isozyme activity within the liver itself. So liver function, in terms of, liver activity is not a huge limiting factor for drug clearance. However, because they're so efficiently cleared, right, through circulation, when you have diminished blood flow in the liver, it could potentially cause accumulation. So examples of these drugs include fentanyl, sufentanil, morphine, propofol. So you're seeing where I'm getting at here. So this could potentially cause some accumulation of these sedative products. Okay, and some studies have shown that the serum concentration of these products with high extraction ratio could actually increase by 2 to 12-fold. So that's very, very significant. So when we're looking at titrating these drugs, right, we just really need to be cognizant, if their event changes, right, there are other things that are changing within the patient that could potentially influence how much drug they actually require. Sometimes it's very difficult to gauge that if they're being paralyzed. But again, we should actually do our part to kind of anticipate some of these problems and maybe avoid agents that could potentially cause a lot of issues. Okay. And so the next thing I kind of want to just briefly touch upon would be cytokine storm. So it's shown that COVID-19 patients have very profound pro-inflammatory kind of activation. So you have a lot of acute phase proteins as well as cytokines in the system. And studies have shown that cytokines actually could inhibit your P450 isolase enzyme system in hepatic metabolism. So again, in terms of metabolism, you're looking at reduced phase 1 metabolism, which is all of your CYP enzymes, and then we're also looking at some level of phase 2 metabolism reduction to a slightly lesser degree. So again, we're looking at accumulation of drugs with extensive hepatic metabolism, and examples of that would be morphine, midazolam, and phenobarbital. So after just speaking about all of this, the question is, so what is the ideal agent for these patients if they have all these issues? Really, there is no perfect drug in any situation. However, every drug has its role. So as long as we can fully understand their properties and how they behave in the human body in your critically ill population, then we can make the best decision in terms of optimizing our drug therapy for patients during this very difficult surge period. So that really leads me to sum up the whole presentation today, right? Some of the key takeaways would be to consider alternative routes. Sometimes it's not preferred, but for certain patients, it could actually work out very well. So that's, again, your PO and G access, your IV pushes. And most importantly, we want to remain flexible. We may have to be creative with regimens to really maximize the optimal use of what we have. And we really need to understand the pharmacokinetic properties of these alternative agents so we can use them safely and anticipate any sort of side effects, really to prevent any complications. And ultimately, it's all about open communication and team effort in the caring of these patients. So that's the key takeaways. And next, thank you all for tuning in.
So thank you very much, Krista, for being involved in our webinar this morning. I think, that was very interesting to hear. And it's definitely a challenge. Fortunately, it doesn't seem like we've really had to get to the point where we don't have medications available for sedation or analgesia, but that is kind of a really challenging thing to foresee the potential of. And glad that your team has really kind of planned to position, at least us as best possible. I hope this is helpful to our community partners, that they can think about how their pharmacists can work with their teams on this topic. And so, yeah, if you are part of the community partners and you have a specific question, then please point that to our team. As well, if you have a particular topic that you would like to see covered, please let us know about that. We want to make sure that these sessions are as helpful to you as possible. And so we feel like we've included a lot of different things that would be helpful, but I'm sure that there's other things that might be helpful for you to plan. So thank you. I think that's going to close out today's webinar, and hope you all have a wonderful day.
Thank you.